Last presentation, my hemodynamics marker failed me. Dr. Rafael Go.
He's all right.
We saved the best for last.
Thank you. All right, good afternoon, everyone. For those who don't know me, my name is Rafael Go, one of the second-year cardiology fellows at UT. Thank you all for being here. So today I'm going to present a case that I was fortunate to be a part of with Drs. Manuvala and Dr. Jumian, presentation entitled My Hemodynamic Markers Failed Me. So let me get on right to the case. So I'd like to present a 69-year-old patient with a history of hypertension and lipidemia who presented with acute chest pain. This woke him up from sleep, described as substernal pressure-like, non-radiating, and the patient was previously told that he had intermittent chest pain on exertion, which was relieved with rest prior to this, but never saw a cardiologist prior. EMS was called, aspirin was loaded, and nitroglycerin was given, and this was the EKG upon presentation in the ER. As we see, significant ST elevations in the anterior leads and the high lateral leads with reciprocal changes of the inferior leads, which kind of points to a proximal LED occlusion. So cardiac catheterization lab was activated as a STEMI. Interestingly, the hemodynamic markers were relatively stable. Blood pressure was around 90/60. Heart rate was in the high 40s, still in sinus, and the patient's oxygen saturation was slightly dwindling at around 91%. He was requiring 3 liters. But the labs were fairly stable at this point, and this was one of the initial images that we got in the cardiac catheterization lab. As we see, there is a clear stumping of the proximal LED here, and no flow distally as well. So decision was made, obviously, to revascularize this vessel as soon as possible. A 3.5 millimeter by 15 millimeter drug-eluting stent was then placed, and as we see here, there was a good result in terms of revascularization. Unfortunately, during the course of this, the revascularization process, the patient became progressively hypotensive, had some flash pulmonary edema, and frequent runs of non-sustained ventricular tachycardia. This was one of the ABGs that was done during the case, and as we see here, significant respiratory acidosis with hypercapnic and hypoxic respiratory failure. The lactic acid, as well as you see in the bottom, was trending up at this point. So the patient was emergently intubated, and an intra-aortic balloon pump was placed. During the course of all this, an LV-EDP was obtained and was seen to be around 26. Given the progressive decompensation of the patient, it was decided to place an Impeller CP to upgrade the intra-aortic balloon pump, and a PA catheter was placed during this time while the Impeller was running. At this point, just to point out, there were no pressors yet on board on the patient. The patient was still relatively stable. So as we see here, these are the numbers that we obtained, and clearly we see elevated biventricular filling pressures. We see pulmonary hypertension, all likely driven by elevated left-sided pressures. And the PA sat at around 68% with a FIC cardiac index of around 2. So just a quick recap on where we stand right now. So this is a 69-year-old male who presented with an anterior STEMI. He had a successful PCI of the culprit LAD. He had worsening cardiogenic shock during the case, had to be intubated, and was on Impeller. And while on the Impeller, the PA saturation was around 68%, and the FIC cardiac index was 2. So I'd like to kind of throw this question at the audience with a show of hands. How many of you guys think it would be reasonable at this point to call it a day in the cath lab, bring the patient back to the ICU, diurese them, and kind of monitor them at this point? Okay, see a few hands there, okay. So interestingly, as we evaluated the patient, looking at the lower extremities, we see here the right lower extremity. There's significant skin changes and mottling, as we see. We took a look at the left leg, and same thing also, some skin changes and mottling. And as we palpated the feet and the rest of the lower extremities, they were ice cold. And at this point, we decided that this patient was still likely not perfusing very well. So at this point, the decision was made to cannulate VA ECMO on the patient, and patient was then stabilized and brought to the ICU. Just for the sake of brevity, to keep everything short, the story did have a happy ending. The patient initially required some pressors and inotropes, but eventually was weaned off fairly quickly. The patient was decannulated from ECMO around 3 days after, and decannulated from Impeller 7 days after presentation. The patient was then subsequently discharged after 20 days with some little bumps here and there, but relatively okay. And this was one of the echocardiograms done prior to discharge. Initially, the echocardiogram showed a lot of wall motion stunning, but now we see there's a lot more recovery from that standpoint. So I'd like to kind of finish with this slide here. I think the teaching point for this topic is a simple one, but very important. In the heart failure world, especially in cardiogenic shock, we use our invasive hemodynamics very, very well. We know its utility. It can help us diagnose, and it can help us guide our management strategy. But as we see here in the slide, there are a lot of limitations that we need to take into account whenever we're looking at these invasive hemodynamics. There are assumptions that are made, and based on that, some limitations in terms of our measurements. In this particular patient, for example, everything happened very acutely. It's hard to say exactly why the patient's hemodynamics may not have correlated with the clinical picture. One thing to understand is whenever we take these hemodynamic measurements, these are basically a snapshot of the patient's situation. It's possible that as we started the Impeller, got these measurements, that potentially the patient was relatively stable at that point, but then started to keep decompensated further and further down. So I think the takeaway point here is important. Invasive hemodynamics are important for us to help guide our strategies, but I think we should not just completely rely on them. And that's it. Thank you.
Did you entertain any other causes for that lower extremity perfusion issues on this patient?
Yeah, so the patient did have bilateral lower extremity access. So it's possible that we were thinking initially that potentially there could be an access issue there. The patient did have some issue with the left femoral access, but the fact that it was bilateral, the fact that the patient had poor perfusion in both legs made us think that this was more of a global picture rather than just an isolated access issue.
So 2 questions. After the Impeller was placed, number 1, what were your pressures like? And number 2, I know you guys got, it looks like an ABG and did a right heart cath. Was that PA sat on supplemental oxygen?
Yes, the patient was already intubated at that point. And yes.
You were on a pretty high degree of FiO2 on the
Correct. It was around 80 to 100%, if I'm not mistaken.
So I think there is some notion of that can affect your PA saturations, which can lead to falsely high or even abnormal FIC output. So Dr. Nathan actually taught me this on a few of our LVAD patients. We ran into this issue is we use the FIC output, and that's usually not a good marker that there is a discrepancy between the TD as well as the FIC. Mm-hmm. So in this situation, I think using a falsely elevated PA saturation, you got a false marker that there may be some cardiac output issues, and hence the picture that you presented.
Yeah, completely agree, yes.
One small comment. Already on the ED admission, there were some signs on very low cardiac output. I mean, even though lactate was not that high, you had for a heart rate of 50, you had a very narrow pulse pressure. You have 90 over 60. So 60 is quite high for also this kind of bradycardic aspect. So it is a vasoconstricted patient. And a low pulse pressure, so low cardiac output. So already these signs pointed out that this patient was close to fall down in cardiac shock at that point.
Mm-hmm. Yes, and I think the fact that the oxygen saturation had been dwindling during the case was a clear sign of that. Agreed.
All right. Very interesting this session, and thank you, everybody.
Thank you.